Well, good evening, everybody. I'm Dr. Brian Dishinger, and my partner, Dr. Bill Houskamp, is here as well. We're both going to be speaking to you tonight. I get the pleasure of starting. We're talking about heartburn, which is a fancier way to say GERD. GERD stands for gastroesophageal reflux disease. We're both general surgeons here at Holland Hospital. We both work in the Reflux Center, which is part of the endoscopy unit here at the hospital, and I think we're working on well, besides educating people, trying to streamline the process for getting patients in for GERD evaluation. So this evening, our goals of this lecture are going to be to talk about gastroesophageal reflux, explain the overview, some of the factors that can cause people to have this problem, some of the complications of long-standing GERD, and then we'll get into symptom management, including some of the medication options, and lastly, some of the treatment options, including surgery, because you are speaking to two general surgeons. So we will also save time at the end, hopefully, for questions and answers. Obviously, as I'm going, if you have any questions you'd like to interrupt, feel free, just raise your hand. We can move through our slides pretty fast sometimes. So again, gastroesophageal reflux disease is the topic. We're talking, again, about these issues. It's a big problem, as you can see. I think it's interesting how many people take medication for heartburn in this country. Now that the medications are often available over the counter, it's a staggering number of patients. What we really would like to avoid is people progressing, where their GERD, which can be a benign, kind of troubling symptom, can progress to having an actual precancerous condition. And that's what Barrett's esophagus stands for, is a precancerous condition. This is, of course, a diagnosis that would be made during an endoscopy procedure with one of us. But yeah, this slide is really just meant to show everybody how common this problem can be. I like this picture. We borrowed this from our friends at Medtronic, but it just kind of shows some anatomy of the esophagus. Right at the bottom of your esophagus is I call it a one-way valve. It's the lower esophageal sphincter. It's kind of a muscular sphincter that's supposed to be closed. When it's closed, nothing can get out. Stomach acid can't escape into the esophagus. But for a lot of reasons, and we'll talk about some of those tonight, the lower esophageal sphincter can weaken, and that allows gastric acid to leak backwards or reflux backwards into the esophagus. So that's something we're going to talk about here as the night goes on. So this is sort of another pictorial view of that process: stomach acid and bile in the lower esophagus creating damage. It's supposed to be tight. What causes the lower esophageal sphincter to weaken? Well, some of the time we just don't know. Family history, obesity play a role. Certainly a history of obesity creates a lot of internal pressure in the abdomen, and that pressure can stretch the diaphragm. I think as we get older, we all know we lose a little bit of our muscle tone, and I think that since this is a muscle, I think it's just age-induced as well. I think you see it progressively throughout life. So we talk about the hiatal hernia. I'll go back one, two. The diaphragm is a muscle that separates your chest from your abdomen. They call it your breathing muscle. That normally runs right through here. Your esophagus passes through the diaphragm. The opening of the diaphragm is referred to as your hiatus. So that's where the word hiatal hernia comes from. If the hiatus of the diaphragm becomes enlarged, if it stretches, a person can develop a situation where their stomach is allowed to slide into the chest, and that can also weaken the lower esophageal sphincter. It can make it easier for acid to escape. It can certainly predict patients who may have trouble with medicine only. You know, people with hiatal hernia are hard to control with just pills. So that's something that we would discover oftentimes during an endoscopy procedure, and it's certainly something that can be corrected surgically in the right group of patients. So common symptoms: heartburn, regurgitation, all these things, hoarseness, difficulty swallowing. You know, these are all part of the GERD pathway. For some patients, I just saw somebody today at the office, it was more of a throat issue. Upper throat, sore throat, wake up with a sore throat. But when you started to ask more questions, they also had some difficulty swallowing and regurgitation. So some of these are considered atypical symptoms. You know, I think most of us would probably agree when you have chest pain, the first diagnosis isn't GERD, it's probably cardiac disease, but certainly some of these more atypical things can be related to GERD. So GERD can come in many shapes and sizes. This is the classic appearance of somebody who's suffering at work, at home, just kind of regurgitating acid, and it kind of makes a burning sensation. Certainly this is a quality of life issue. I think that's one of our biggest things when we see patients in the office, is that we want to go over how does this affect you, not just minute to minute, but throughout the day, your work, your food, your life. These are all parts of, I think, trying to figure out what's the best way to treat you and which modalities are best. Is medicine, surgery, both, something we need to do. Obviously, if you don't treat your GERD, it gets inflamed. So if acid gets into your esophagus over time, it can cause erosions, inflammation, and these are just the words that describe that. Esophagitis means inflammation of the esophagus. Stricturing is a scarring condition that can lead to narrowing of the esophagus, difficulty swallowing. People often describe the sensation that food sticks when they swallow it. It's usually meat, bread, pasta, things that aren't chewed up very good. Is what you see a lot of that. We'll move on. So this is what I was talking about earlier. Barrett's esophagus is a precancerous change where the lower portion of the esophagus becomes inflamed, and it's really a chronic condition. It's caused by acid contents over time. The lining starts to begin to change cellularly, and then these patients can develop over time cancer of the esophagus. Again, it's not common, but it's something that you should be evaluated for, especially if you're having GERD symptoms on a regular basis. Just a scary picture here that shows what esophageal cancer looks like. We never want to see this when we put a scope down somebody's throat in the endoscopy unit. This is always bad, and fortunately we don't see it that often. But certainly this is a progression of the disease process and kind of an end stage issue. Some statistics here: 11th most common cause of cancer death, 17,000 cases in 2018. So the incidence, this is probably the most important thing, is on the rise. More and more people are having this because more and more people are having GERD. So untreated GERD, I think, is implicated in this rise in the incidence of esophageal cancer. All right, so I'm going to go over some of the diagnostic tests. These are the things that we're going to be doing more of here. We've been doing them for years, but I think we're trying to consolidate testing and get it done more efficiently. So one of the things is obviously medication therapy. How you respond to your medicine is a test in and of itself, and that's an important note. If you take the medicine correctly or incorrectly, do you take it in the morning? That's ideal. So that's one of the things that when we talk about diagnosis, we like to know, did the medication help? EGD stands for upper endoscopy. The E is esophagus, G stands for gastric, and D stands for the duodenum. So basically, in a 10-minute procedure, which is done under sedation, we can pass the scope down and look at all three of those things and make a determination if there's any inflammation, hiatal hernia, things of that nature. pH evaluation is exactly that. If you can remember high school chemistry, you can remember the difference between an acid and a base. So the stomach creates acid, so the pH is low. Neutral is 7. Water has a pH of 7. So we can monitor somebody's pH, and we can assess whether or not it's, typical or atypical. I think everybody's going to have some acid in their lower esophagus from time to time, and really the question isn't, is it yes or is it no? It's how bad is it? So we like to measure it. We can objectify it and compare it to normal, and then give you an answer on how bad you are compared to everybody else. So that's one of the things we like to look at. I guess this slide was left intentionally blank. Just kind of a header slide leading into this. So medical therapy, doesn't have to be a pill. It can be just some of the lifestyle modifications. We talked about how obesity and weight gain is implicated in this. Eating, I do it. I do it at work, I eat too fast. I do it at home, I eat too much. So these things stretch the stomach. They put pressure on a hiatal hernia. They put pressure on the diaphragm. Certain foods have been implicated to be stimulants for acid production. It's all the It's all the good stuff, but these are things that many of us have to avoid if we want to avoid heartburn. Medication management, there's all different kinds of heartburn pills on the market. There's a variety of different ones. They work different ways through different mechanisms. I think we're leading up to that, so I'll say more about medicine in a minute. But again, more stuff on dietary modification, elevating the head of the bed, couple different ways to kind of get your head up at night. That helps with reflux, it helps with snoring, I hear. But anyway, those are some of the options out there for people to avoid, certain foods, change the way they sleep, change the way they eat, don't eat before bedtime. Here we are. This is the slide I was thinking of a minute ago. Some of the different antacids. Acid-base, back to high school chemistry. If your stomach's got a low pH, these have a high pH. You mix them together. The goal is a pH of 7. They work for a very short time. They can provide instantaneous relief, and they're available obviously over the counter. Everybody has Tums at their house or some variation of that. The thing is, they don't work for very long. These medications here are H2 stands for histamine. So this is a histamine channel blocker. Histamine is one of the cellular pathways acid is produced inside your stomach. So when you take one of these medications, it'll block acid production. Again, you want to shut the acid off before you eat. So these are generally taken in the morning before food is ingested. And they're often taken every 12 hours for maximal benefit. And these are considered an in-between to the proton pump inhibitors. A couple examples, OTC, over-the-counter. Prilosec is the brand name, omeprazole is the generic. Very common, relatively inexpensive. Different brands are available. These are the brands. These medications also work to block acid production. They should also be taken in the morning before a person eats. They typically last for 24 hours. So generally speaking, these are going to be the Cadillac of heartburn or acid inhibiting medications. A lot of people will try both and have different and varying effects. So we're going over some more things here about what medicines can do and what they can't do for us. I mean, there are some limitations. Certainly when we talked earlier about the muscle, the sphincter muscle at the bottom of your esophagus, we realized that if it's weak, is always going to be weak. Pills aren't going to make that tighter. We realized that if a patient has a hiatal hernia, reflux is going to happen. Patients still have breakthrough symptoms with medications, so it's not always the right choice. A pill a day for the rest of your life, that's a lot. So some people want to come in and talk to us about trying to get away from needing a pill every single day or multiple pills a day. These medications all cause various side effects. Most of them are going to be related to the GI system. You're taking a pill, you're blocking your acid, so some of the side effects can be upset stomach, diarrhea, things of that nature. We're kind of moving quick, but right out of medications and into the surgical options, this is sort of where we sort of switch gears a little bit and get into some of the testing that we do here, and then that leads up to the treatment. So patients who would consider, at least talking with the surgeon for GERD or heartburn would be patients who are experiencing breakthrough symptoms on their pills, symptoms that occur despite the use of medications, or symptoms that are worsening, where it affects the quality of life, and then people who have concerns about progression of their disease. Barrett's esophagus, obviously nobody wants that, nobody wants cancer, and these are some of the ways we kind of look through it. So being free of medications is certainly an option when you consider some of the surgical techniques. So this gets into the pre-op evaluation. I'm going to let Dr. Houskamp stand up and introduce himself and say a few words so I can take a sip of water, and I won't go far, I'll just be here.
Yeah, my name's Bill Houskamp, and I'll continue with some of the discussion of how do we work it up, how do you really know you have reflux. We all, I think, intermittently will have reflux to some degree, and a lot of times we have reflux. I don't know, it's on. Am I talking loud enough, or? He always is louder than I am. My green light is on. All right. Studies are very clear that just because what we think are symptoms are not necessarily truly acid reflux, and the severity of the reflux, how often patients have reflux, be it weekly, daily. When you actually look at their inflammation on EGD, they often don't correlate, and the symptoms can be very mild or sometimes worse than what we actually find as a disease. So you get an idea of what symptoms are, obviously, by listening to your history, and we know it. And like Brian said before, a good test is if patients say they responded well to the medicines. The medicine, particularly the PPI therapies like omeprazole, Nexium, all those different name brands, it's so effective that if it doesn't work, that alone makes you step back to say, does this patient really have reflux? Because the medicine is so good at blocking the acid production in the stomach. It actually works on the cell in our stomach that makes the acid. And only a small percentage of patients don't respond to the medicine. So if you have patients that take it, sometimes we'll even do a double dose therapy, higher dose in the morning or twice a day. We'll do that for a period of time. And if they're taking it appropriately, usually 30 minutes to an hour before you eat breakfast, and they get no response, that alone tells you, okay, maybe this person doesn't have reflux. And then there's a lot of other things that can cause those symptoms. And that's part of the whole evaluation that you go through to say, well, not just the treatment, but are you getting the right treatment? How bad is your reflux? Do you truly have reflux, or is there something else? So how do we go about that? The first thing would be to do an upper endoscopy, where we look. Dr. Dishinger explained that as well. It's pretty easy, quick test, relatively low risk. They make you nice and sleepy for it if you've ever had it. I've had it. Next thing you know, you're back in your room. During that test, we're able to obviously get a good look, evaluate for a hiatal hernia, actually look at the signs for inflammation. And then the most important thing is we do biopsy, look for signs of inflammation on a biopsy that confirms it, and then make sure there's not any atypical cells and some of that progression from Barrett's to an esophageal cancer. We get an idea of the presence of a hiatal hernia. Again, not everyone with reflux has hiatal hernias, but they often go hand in hand, and you can have a hiatal hernia and not have reflux. It doesn't necessarily mean you're going to have it, but they frequently go hand in hand, as well as to make sure there's no other problem that, again, where patients can think it's reflux and it's something else. It's something in their stomach. They have a gastritis, they have an ulcer, they have something else that's not been diagnosed. They have eosinophilic esophagitis, another thing that can cause problems in the esophagus, that patients will have trouble swallowing. They can have symptoms that we just generically said, oh, it must be reflux. When you work it up, you find it's not necessarily the case. The importance of pH monitoring. Brian mentioned that. What is pH monitoring? We essentially want to know, well, how much acid is in someone's esophagus during the window that we're testing it for. It's pretty much for us the gold standard to know how bad someone's reflux is. Do they really have reflux? And get a better sense of their symptoms and correlating with reflux. The way it's been done for years is essentially a tube goes down your nose and it goes into the esophagus, and at the base of it, it has a way to measure the pH, and that sits just above what we call the gastroesophageal junction, so the distal part of the esophagus. And then you go around for 24 hours and supposed to do your normal things, eat normally, go to work, do all those type of things. And during that time, both during the day when you're upright, laying down, of course at night when you're sleeping, we are able to measure how much acid is in your esophagus when it shouldn't be there. We have normal, all have physiological reflux where we burp, and then what is it abnormal based on, again, thousands of people studies where they get baselines and what's normal individuals and what's not. And during that time when you're experiencing symptoms, you actually write them down, and we can see, well, this patient's feeling like they have heartburn, or they feeling like they have chest pain, or they feel like they have regurgitation where things are coming up. We actually can look at the monitor and say, well, yeah, this did correlate with it, and say, look at this, they had a lot of acid in their esophagus when they're feeling like they have heartburn, regurgitation. At the other end, we'll see, well, again, having chest pain, having regurgitation, symptoms of what they would classify and have always classified for heartburn or GERD, and then you look and there's actually no acid in their esophagus during that time. So that's for us saying, well, you have symptoms, but it's not GERD, it's not heartburn, it's not from acid reflux, it's from something else. And then again, our job is to look for something else. But that's really how we define how bad it is. Does it really correlate with symptoms? And that's kind of the main way that's been done for years. And then now we do it, we still do it that way depending on various scenarios, but the other way that's done is when you get your EGD, meaning when you're asleep getting your procedure, after that procedure we do what's called a Bravo test. And what's done is a little chip is placed 5 to 6 centimeters above the gastroesophageal junction, and we actually suction it to the esophagus, and that sends information to basically a little computer that you wear, and we can do that up to 72 hours. And so now we get a longer time frame of being able to get because that's another thing that's amazing. And just, I guess, like all of us, we have good days and bad days, and you'll see some days that don't have much reflux or what we would still call abnormal, but then other days it's really bad, and sometimes you can get a better sense of it with 3 days. The same concept in that you write down your symptoms during that time frame, and we can look to make sure that when you think you're having acid, when you think you're regurgitation, when you're having a typical chest pain, we can look at the monitor all during that time and see if you're having symptoms or not. The other thing that's really helpful is a lot of times things are occurring at night when you're sleeping, and you may not have enough acid reflux that comes to the back of your throat and wakes you up, but there's enough that's causing damage during the night that you have heartburn, ongoing inflammation that you may not even realize is causing symptoms because it's occurring a lot at night. And so we get a good, ideally a 3-day window of being able to evaluate that. Yeah?
Is that an alternative then, the Bravo test versus the one where you're...
Yes. Yep. And that's, yeah. If someone, there's different scenarios. If someone had just had an EGD, do I really need to make them, even though the risks are low, but do they really need to go back and have another EGD, go to sleep, be NPO, all those type of things? So I kind of say, well, when was your last EGD? If you've had one, if we're going to pursue that. So there are variations that you might not do that, but that'd probably be the most classic. Yeah, no one wants to wear a tube in their nose for 24 hours if they don't have to. Yeah, it's kind of tough, and it's tough to get them to be normal, or as far as have a normal day of normal eating. Go to work with a tube in your nose. It can't all be done on a Friday. Barium swallow is again, it's a relatively cheap, easy test for us to do. You can go drive yourself there. You can swallow it. We get a good idea. With that test, we can see if there's any obvious abnormalities, such as a defect that would suggest there's ulcerations. We might be able to see, heaven forbid, a filling defect where there's a growth or like a cancer that's growing, a narrowing that can occur where it gets narrowed down. That can be from the sphincter itself. That can be from years of reflux where it scars in. We get a sense of the hiatal hernia. Again, that's the opening in the diaphragm. If we see the stomach is actually, on the contrast study, is in the chest, that can tell us how big the hiatal hernia. We'll see someone who has a really bad opening, and half their half their stomach or their whole stomach can be in their chest where it shouldn't be, as opposed to in their abdominal cavity. Just a normal study, they watch it go down as you drink, and you can kind of get an idea of how the motility is, meaning how does the esophagus propulse. At least get a sense that, oh, it doesn't propulse very well, push things down. So we often get that study as well, which leads us into the next one, which is where we're really looking at esophageal manometry. We're really looking at how well the esophagus pushes things along. We get a sense of that with an upper GI, but this is where we're actually measuring the how well does your esophagus propulse? Is it normal? Is it not normal? Is it how bad is that sphincter? Does the sphincter actually work? What is the pressure that it can generate, just like if you use your arm to generate how much pressure it can be? And this, again, is a real important test for us surgically if we're going to do anything surgically, but it's also important for those tests for those patients who don't respond, because when we actually pursue, okay, well, they didn't respond to medicines, they get either their 24-hour pH study or a Bravo study, the correlation of symptoms and the acid didn't fit. Where they're having symptoms doesn't fit when there's acid in their esophagus. So then we're looking for other things, and that's when manometry can be extremely helpful, and we find that they have a motility issue. So they have a spasm in their esophagus. They have esophagus doesn't work well. They have a lower esophageal sphincter that maybe is weak, or the opposite, where it doesn't open up. And all those things can cause symptoms, which often we just generically call, well, that you must have reflux or heartburn or something related to that. For a surgeon, if we're going to do any type of surgical intervention, we want to know multiple things with how important this is. For number one, we actually can measure the lower esophageal sphincter pressure. And again, what causes reflux is really a combination of things, but the lower esophageal sphincter its strength is the main component. And then the contributing factors are the weight of the patient, things we don't necessarily understand, and a hiatal hernia is a big contributing factor. All those initial things that Brian talked about are focused in on acid reflux, or focused in on the acid component. But the reason you have reflux is not the acid. We think of that from the old days of really like peptic ulcer disease. That was an acid problem. This reflux is not an acid problem. We treat it by making the medicine or making the acid alkaline, but it's not an acid problem. It's a reflux, and that's an anatomy problem. It's a sphincter problem. We treat the symptoms by treating it with medicines that block it, so it's an alkaline, so we're blocking acid production. But the actual reason why we have reflux is that's not being treated with the medicines. So that's where the manometry is real important, that we're measuring that sphincter. We find out the other thing that is a big helpful is we measure how well the body of the main part of the stomach, or the esophagus, what we would call the body of the esophagus, pushes things along. Those patients who respond really poorly to the medicines are patients who have a weak sphincter and a weakened esophageal pressure, the body, as far as how well it propulses. The medicines, if you have a manometry and you have a normal lower esophageal sphincter, or close to normal, and you have a normal body of the stomach, or the esophagus, that pushes things down, those patients respond very well to the medicine. If you have patients who have a weak sphincter, but their propulsion is normal, they will still respond okay to the medicine, but 40% of them are going to have ongoing issues, which is why we see so many people, they have improvement, but their symptoms don't resolve. And the patients who have both problems, where their esophagus doesn't push well things down and they have a weakened sphincter, respond really quite poorly, because it's the regurgitation of things. So it's a combination of that. If we're going to create a new valve, be it surgically, of whatever different surgical approaches someone has, if they have a esophagus that doesn't work and they can't push things down, and we create a new valve, so now nothing can reflux up. That one-way valve is now created again, where nothing can go up. Well, the good news is you won't have regurgitation, you won't have heartburn, because we've created a new valve. The bad news is you won't be able to swallow, because your esophagus isn't good enough to push things to open it up. So we've replaced one problem and created another. So that's, again, a lot of manometry is key to not only surgical decision-making, but really understanding patients' full disease, particularly those who don't respond well to the medicines, and you're trying to figure out why are they not responding to the medicines. Again, the benefits of operative therapy, a lot of it comes back to regurgitation. Again, the medicine works really well. We said that. So what can happen is they don't get acid reflux anymore. They might not even have heartburn, but the symptoms that if they really have a weakened lower esophageal sphincter combined with a hiatal hernia, the problem that doesn't get treated at all is the regurgitation. So again, particularly at night when they lay down, things will come to the back of their throat. They can wake up with bile in the back of their throat. If you've had it where you eat and you bend over, and because there's so little of a valve, the regurgitation symptoms is what bothers them just as much. And the medicines aren't treating that, it's just making it alkaline reflux. So you have a reflux that's now neutral or alkaline as opposed to being acidic. So those are, again, the patients, if they have an anatomical defect that we can surgically repair, those patients are definitely it's like if you fixed a groin hernia or a belly button hernia. It's the defect that we're trying to fix, so we're fixing that hiatal hernia, combined with if they have a weakened lower esophageal sphincter, we're recreating that valve for them because their sphincter doesn't work like it used to. And again, why that happens, we don't really know. Some people it does. Definitely, again, family history, you listen, everyone in their family has reflux, but a lot of times we don't know why that valve starts to not work as well. I mean, you have patients, or maybe it's yourselves, that have had reflux since they're in their 20s. As long as they can remember, they've taken medicines. So the gold standard, what's been done for years and years, is what's called a Nissen fundoplication. Essentially, Dr. Nissen created that. What occurs in that operation is the we're trying to recreate that valve. So the first part of that operation is where we're going to fix their hiatal hernia if they have one, or even if they don't have much of a hiatal hernia, just that opening itself where the esophagus goes through the diaphragm, we're going to fix that, repair it, make it tight again. That's really the first part of the operation. Most patients have some degree of hiatal hernia, but that can be just small, potentially not even clinically significant, but they have some form of hiatal hernia most of the time. But that opening, we want to make that tight again. A lot of times with the hiatal hernia, they may have an opening that's gotten bigger, or it can be the point where that stomach is now pulled above the diaphragm. This is, again, the diaphragm separating our chest cavity from our belly cavity. And with time, if that opening gets big enough, slowly the stomach pulls into the chest cavity. The chest cavity is actually a negative pressure cavity. The abdominal cavity is a positive pressure cavity. That alone, as we take a deep breath, it's negative pressure. It actually weakens that pressure zone even more, leading to more reflux. If you have patients that have a hiatal hernia, then that contributes to that. If you get enough of your stomach in there, then you can not only have reflux, but sometimes you get to a point where you don't have reflux anymore because the stomach's kind of pushing it, and those patients tend to have more what we would call dysphagia, meaning they just have trouble swallowing because half their stomach or part of their stomach's in their chest. And if it can get to the point where half of it, it can actually lead to breathing problems and other types of symptoms where people have trouble breathing because there's too much stomach in their chest. So first part of the operation, we fix the hiatal hernia, which most of them have, and we retighten that. Doesn't really show stitches there, but that's what we call the hiatus, which is the opening. The second part of that operation is to recreate the valve. And by doing that, the fundoplication part is a fancy term to describe the top part of our stomach. It's called the fundus. And essentially, we take the top part of the fundus and we wrap it around the esophagus. Kind of like what we always talked about, like a hot dog in a bun, where the hot dog is the esophagus, the bun is the stomach, and we're rewrapping that, creating a new valve. It also changes the angle, which is what we call the angle of His, which is essentially the same angle that we ideally have, which is also part of that mechanism of that high pressure zone between our stomach and our esophagus, which is lost. It straightens out when we have a hiatal hernia. And you can see to do that, we're actually, the benefits, long term, reduces symptoms. People don't have heartburn, they don't have reflux. It works really well for that. It's been done since the early 70s. Most of the time it will heal the damage to the esophagus. It says may because nothing's 100%. Most patients get off medicines with time with that. It's really something, it's like surgery. Any surgery is invasive, no matter what type of, as a surgeon, we worry about that. No matter what we do, surgery has some risk. The good thing is patients don't have reflux, they don't have regurgitation. The bad thing is that we're really creating a good valve. It's really, really good. And it's essentially, we've now created a really good one-way valve again, and it's better than how God created it in the first place. And that patients can go this way, but they usually, ideally they can, but most patients can't belch, they can't throw up. So if you get sick for all different reasons, it can only go one way. It goes this way and not this way. So that leads to other potential symptoms. Not only initially can they have some trouble still with swallowing, but complaints of gas bloat, they feel full, they can't burp. If they do get sick, they can't throw up. That's not a very pleasant experience as well. When they do throw up, is the potential of tearing that, so disrupting their wrap. They may pass more gas because the gas has to go somewhere. It goes out the other way as opposed to up. And the other thing is, to do that, we're obviously changing the anatomy of how God, again, gave us the anatomy. This part of our stomach is attached to the spleen, which is over here. It doesn't show that. So we have to take the stomach where it attaches to the spleen down. We're changing the anatomy and sewing it in place. If it doesn't work in the future, it makes it more difficult to make it better, redo it. All those are difficulties with the fundoplication long term. There's at least 10% of patients, it works great for 10 years, if not higher, and then they have to redo it and do it again. And each time you do it again, it's less effective with more complications, a really hard operation that when you redo it, because everything's been scarred down, and then you got all these important structures that have been sort of glued together here, and it's really a much more difficult operation, and the success rate goes down with each time you try it. So that's it works really well. It has some really good things to it, but it has some downsides. A newer way that's been done for probably 7, 8 years, at least here in the States and longer overseas, is what's called a Linx procedure. Again, it's the same concept. You're trying to recreate that valve in a less invasive way. This is what we call it's a special titanium magnet, and these come together like this, and that essentially recreates that valve with this, and that these are open, they can open and close. When it's in its neutral state, it sits right again at the gastroesophageal junction, and that it's now a two-way valve, as how, again, what we have now, where it's supposed to be kind of a one-way valve, but we can burp it through it, we can throw up through it. This is a two-way valve, and that opens and closes. So it opens up when we eat, it closes when it's not eating. It prevents, it's not a super tight, it's just enough that we can still burp, we can still belch, you can still overeat, which we all do too often, unfortunately, and you can still have symptoms of regurgitation. But the idea is to create this sphincter augmentation, recreating the sphincter with this magnetic valve. Here's a picture of where it sits. So again, right here at the junction, and this allows food to go this way, expands. As our stomach expands, this is where that junction gets stretched, which makes us prone to get reflux, particularly when we overeat. That gets more and more thinned out, and this allows that to still happen where food goes down, but yet we can still burp, we can still throw up. It's a two-way valve as opposed to a one-way valve. Those patients that have less of the side effects that a Nissen has, which is, again, the bloating, belching, feeling full, less gas bloat, usually less issues with swallowing, both short-term and then long-term. When we think back of, at least for us, how we put it in and the invasiveness of it, the operation with a Nissen, and there's other, this is like the gold standard, but we do other ones, other types of surgical repairs where this part of the stomach we might do a toupee, which is a partial wrap. There's a lot of different variations over that have been described, but the concept of recreating that valve with our natural anatomy. The operation for a Linx is that part of the operation we're not doing. We're still fixing your hiatal hernia. We're still tightening that part of the diaphragm. Whether you have a hiatal hernia, don't have a hiatal hernia, that part is still done. It's the second part of the operation that we put the Linx device, which fits there, as opposed to taking these structures down. So we're not changing your anatomy. We don't have to take the stomach attached to the spleen, which can be an issue. We're not changing the anatomy, so theoretically it could be removed. You could still have a Nissen fundoplication or some other type of wrap down the road. That's never the goal. It's to be a permanent thing, not to be something that could be removed. But theoretically, it can be removed, and you could still have other therapies because you're not changing someone's anatomy. So that second part of the operation is not done, and we're spending the time creating this. Results have been great. Now getting to be a 5-year data with again patients having good response, where 85% of patients are off their reflux. The regurgitation particularly is a real helpful symptoms that's resolved with you're not regurgitating, but yet you're still able to belch and have less side effects. So that's a huge component of the difference between doing some form of surgical wrap where we change someone's anatomy, be it a toupee, a Nissen, and some of the others that are done. We follow the same quality of life scores that we would look for someone with reflux. There's a little paper, you can actually take your own test and give an idea what kind of symptoms you are when we evaluate that and compare those data. So that's kind of a summary. I think from a surgical standpoint, some of the things that we think of most is that we tend to treat reflux, which is, from our standpoint, it's a weak valve. It's an anatomical defect if you have a hiatal hernia, with medicines that just treat the acid that's coming through, and now it's alkaline reflux. You still have regurgitation of food. You can still have regurgitation of alkaline reflux. That alkaline reflux is a contributing factor to still having risk factors for Barrett's esophagus. Some people believe that's even more of a risk factor for developing Barrett's, and esophageal cancer is from alkaline reflux, because the reflux is still occurring whether you realize it or not. are all things that go on. Even the medicines that we treat, really to know for certain, are you on the right medicines, are the medicines working, you'd almost have to actually put patients on their medicines and do a pH study with them on medicine to say, okay, here you're taking it, but you could see that you still have abnormal reflux particularly at night, so you might have not symptoms from it, but there's still damage that's occurring. So there's a lot of things that when we're just treating medicines, we're not necessarily treating the whole disease.